the 2022 batch uh, to talk about Miss Dr. Senadheera. She's a graduate from the Sri Jayawardenepura University Medical Faculty, and she had been previously experienced in working in ICU units as well as in general services in NHSL. So, without further ado, I hand over to Dr. Senadheera for your presentation. Over to you.
Thank you, Dr. Heliker. Good evening, dear madam and my dear colleagues. Today, I am presenting a case of 15-year-old school student. He presented with yellowish discoloration of sclera for 3 months. When you hear this presenting complaint, what are the possible underlying causes that came to your mind? Any guesses?
Viral hepatitis.
Yes, while viral hepatitis is also a possibility. Hepatitis B and C can lead to chronic liver diseases and persistent jaundice. What else?
Hemolytic anemia.
Yes, hemolytic anemia is also a possibility. Good.
Autoimmune hepatitis.
Yes, autoimmune hepatitis also commonly affect teens and young adults with symptoms like fatigue, joint pain, and jaundice.
Gilbert syndrome.
Yes, it is also a possibility. It often present in adolescent and may cause mild fluctuating jaundice without other symptoms.
Dubbin-Johnson syndrome.
Yes, it is also possibility. Metabolic diseases like alpha-1 antitrypsin deficiency, Dubbin-Johnson
Dr.
syndrome.
Jayamini,
Yes.
can you keep your mic closer to your mouth?
Yes.
We can't.
Now can you hear?
Yeah, it's better.
All right. Right. These are the possibilities I thought of. Viral hepatitis, hemolytic anemia, Gilbert's syndrome, autoimmune hepatitis, Wilson's disease, obstructive causes like cholestasis, drug-induced liver injury, metabolic or genetic liver disorders, and liver tumors. Keeping these possibilities in my mind, I took the history. The yellowish discoloration of the eyes was first noticed by his family and friends. It has remained constant for 3 months with no identified exacerbating factors. This was not accompanied by signs of liver or systemic diseases. He had no abdominal pain, nausea, fever, vomiting, or itching. Both his urine and stool color were normal. He did not report weight loss, change in appetite, anemic symptoms, or signs of connective tissue diseases such as joint pain, alopecia, oral ulcers, or skin rashes. His medical history is unremarkable. There is no history of chronic liver diseases, neonatal jaundice, leg ulcers, biliary colic, hematological malignancies, or recurrent blood transfusion. He had not undergone any surgeries, especially prosthetic valve or hepatobiliary surgeries. He was not on any medications. He has no family history of hemolytic anemia or chronic liver diseases. He is a school student of grade 11. He does not consume alcohol or recreational drugs and was not an IV drug user. And he has no recent travel. He is also not sexually active. His main concern was whether there is any serious underlying pathology. On examination, he was afebrile, mildly icteric, no lymphadenopathy, no signs suggestive of chronic liver diseases such as spider nevi or palmaerythema, no ankle edema. Abdominal, cardiovascular, respiratory, and neurological examination was normal. With history and examination, I narrowed my differential diagnosis into Gilbert syndrome, chronic viral hepatitis, hemolytic conditions like G6PD deficiency, metabolic or genetic liver disorders like Wilson's disease, and alpha-1 antitrypsin deficiency. With these differential diagnoses in my mind, I organized my investigation plan. We did bilirubin levels. His total and indirect fraction of bilirubin has marginally elevated. His full blood count was normal with hemoglobin of 15.8. Blood picture, there was no features suggestive of hemolysis. Retit count, liver function test, thyroid function test, CRP and UFR was normal. Ultrasound does not show any structural abnormalities in the liver or biliary system. So my probable diagnosis was Gilbert syndrome. I explained to the patient that this condition is benign and generally does not lead to any long-term complications. This helped to address his primary concern about any potential serious underlying cause. I advise him to avoid common triggers that can exacerbate symptoms such as prolonged fasting. I acknowledge his worries and emphasize that his condition is not life-threatening. I suggested that he please keep an eye on any changes in
Jamini,
hormones.
Jamini, if
Yes.
you can switch off the mics of the others, it's better. Somebody is like disturbing, they don't know, understand what's the purpose of this particular presentation. If you are not interested, please leave this thing right now. Don't disturb, because it's not a just one day work. It's a huge days she has spent to do this presentation, right? Don't take there's a joke. If you really want to join, concentrate on this, or else we'll give 1 minute to leave this presentation, this particular thing. Don't do any sort of any disturbances, because Yamini, even I couldn't hear because there were a lot of disturbances. Can you just go through the 2-3 slides? I think I couldn't follow last 3 slides because there were like lot of disturbances. I just check who are these guys, but I don't want to tell. But don't do these things hereafter. We really want to stay, otherwise please go. You start with Gilbert syndrome, it's okay, fine. Otherwise, I couldn't hear anything. Not a joke.
My probable diagnosis was Gilbert syndrome. So I explained to the patient that this condition is benign and generally does not lead to any long-term complications. This helped to address his primary concern about any potential serious underlying cause. And I advise him to avoid common triggers like prolonged fasting. And I acknowledge his worries and emphasize that his condition is not life-threatening. I suggested that I suggested him to keep an eye on any changes in jaundice. Finally, I schedule a follow-up with fasting bilirubin level. Then we'll come to the discussion. Jaundice is a condition in which the skin, sclera of the eyes and mucous membranes turn yellow because of high level of bilirubin. Jaundice usually occurs when the serum bilirubin level exceeds more than 3 milligram per deciliter. When we talk about the bilirubin metabolism, the steps are very important in coming to a diagnosis. When the RBC broken down by macrophages, our hemoglobin is released. This hemoglobin split into heme and globule. This heme reduced to unconjugated bilirubin, which is lipid soluble, not water soluble, and it is transport in blood bounding to albumin. This unconjugated bilirubin comes to the liver. Liver is the place where the conjugation happens. This unconjugated bilirubin converted to conjugated bilirubin by UDP glucuronide transferase. This conjugated bilirubin is water soluble. This conjugated bilirubin excreted to biliary system and into the intestine. In the intestine, conjugated bilirubin converted to urobilinogen by bacteria. Some of this urobilinogen is reabsorbed and excreted by the kidney. By the kidney as urobilin, giving urine its yellow color. The remaining urobilinogen is converted into the stalkobilin, which is excreted in the feces and gives stool his brown color. This disruption in any part of this pathway can lead to accumulation of bilirubin in the body, causing jaundice. As you can score, if the hemolysis is increased, if the conjugation is affected, the unconjugated bilirubin will be raised. If there is problem in biliary system or hepatocytes, the conjugated fraction of the bilirubin will increase. These are some causes for unconjugated hyperbilirubemia. I have taken from this start from the American Family Physicians site. And these are some causes for conjugated hyperbilirubinemia. These are some clinical features we should look in a jaundice patient. When a patient appears with jaundice, we have to take a good history and physical examination and do investigations like fractionated bilirubin, full blood count, liver function tests like ALT, AST, ALP, gamma GT, and INR, and albumin and protein. If the investigations are normal, we should consider another cause like carotenemia. If the indirect and the total fraction of bilirubin is high, we should evaluate for hemolysis. If hemolysis is present, we have to treat the underlying cause. If there is no hemolysis, we should consider Gilbert or Crigler-Niger. If the conjugated fraction of the bilirubin is increased, we have to do laboratory assays like viral hepatitis and imaging. If the cause found, we can treat it. But if there is no diagnosis found, we have to do additional advanced imaging. then comes to the management. As I said before, when there is hemolysis, we have to treat for the cause. Uh, in management of hepatic jaundice also depend on the cause. For acute viral hepatitis, especially hepatitis A and E, supportive care is the primary treatment, as these infections are usually self-limiting and do not have specific antiviral treatments. This include rest, hydration, and monitoring liver function. For hepatitis B and C, we take a different approach, especially if they become chronic. Chronic hepatitis B and C require antiviral therapy with direct acting antivirals being used early for hepatitis C to improve outcome. Autoimmune hepatitis require immunosuppressive treatment to manage the immune system's attack on liver cells. We typically start with corticosteroid combined with azathioprine. For patients who are resistant to steroid, newer immunosuppressants like mycophenolate profetil can be considered. For non-alcoholic fatty liver disease, lifestyle modifications are the cornerstone of management. This include diet changes and weight loss to reduce liver fat. While there are no specific approved medication for non-alcoholic fatty liver disease, new therapies are being studied, including GLP-1 agonists like semaglutide and SGLT2 inhibitors. In cases where obstructive jaundice is due to gallstones, ERCP is a procedure of choice to remove obstructive stones. For patients with recurrent episodes, a laparoscopic cholecystectomy offers a definitive treatment to prevent future occurrences. When the obstruction is due to malignancies, such as pancreatic cancer, we have used palliative stenting to relieve biliary obstruction and improve symptoms. In cases where the tumor is detected early, surgical resection may offer a curative option. Additionally, advances in immunotherapy, such as the use of pembrolizumab in certain patients, have shown promise in the treatment of biliary and pancreatic cancers. This slide highlights some of the emerging therapies and recent advances in the management of liver disease. Liver transplantation remains the gold standard and often the only option for patients with end-stage liver disease. It can be life-saving, offering a new lease on life to those with severe liver damage. Advances in transplant techniques, immunosuppressive management, and organ preservation continue to improve outcome and increase the success rate of liver transplants. Gene therapy is an exciting area for research, especially for patients with genetic liver diseases, such as Wilson's disease. This approach aims to correct the underlying genetic defect, potentially offering a one-time treatment that could halt disease progression, although still investigational. Gene therapy holds tremendous promise for transforming the way we treat inherited liver condition. Advanced imaging technique like MRCP and elastography are becoming increasingly valuable in liver disease management. MRCP provides detailed images of the bile ducts and pancreatic duct, helping us assessing for obstruction or structural abnormalities without invasive procedures. Elastography, on the other hand, allows us to measure liver stiffness, which correlate with fibrosis levels, providing a non-invasive alternative to liver biopsy for assessing fibrosis and monitoring disease progression. We, as family physicians, play a crucial role in the initial assessment. However, there are certain situations where a referral to a specialist is essential for the patient's safety and for optimal care. First, an immediate referral is warranted if we observe signs that indicate severe liver dysfunction or potential complications. This includes evidence of hepatic encephalopathy, such as confusion or altered mental status, as well as signs of worsening jaundice with synthetic liver dysfunction like reduced albumin or elevated bilirubin with INR abnormalities indicating coagulopathy. These signs suggest severe liver impairment and the need for urgent specialized care. In cases that aren't immediately life-threatening but still require expert management, we should consider referring for further evaluation. This includes patients with chronic hepatitis B or C should be evaluated for antiviral therapy, as this can prevent progression to cirrhosis or liver cancer. We can refer to STD clinic. If there is any indication that patient jaundice could be due to malignancy or any obstruction, a referral to gastroenterology or hepatobiliary surgery is crucial for timely intervention. If initial workup doesn't reveal a clear cause for jaundice, a referral for further assessment helps ensure we aren't missing an underlying pathology that could worsen over time. As primary care providers, we have a critical role not only in diagnosing and managing liver disease, but also in educating our patients and ensuring proper follow-up. This can significantly impact patient outcomes, particularly in those with chronic liver conditions. The first part is patient counseling. For patients with liver disease or at risk of liver issues, it's crucial to emphasize the impact of lifestyle choices on liver health. Patients should be educated about the importance of avoiding alcohol and certain medication that can harm the liver. Even small amount of alcohol can worsen liver disease. For those with non-alcoholic fatty liver disease, lifestyle changes are the cornerstone of management. Long-term follow-up is essential for patients with chronic liver disease, as these conditions can progress silently. For patients with chronic liver conditions, we should schedule regular lab tests and imaging studies to monitor liver function and catch any progression early. In high-risk populations, such as patients with cirrhosis, regular screening for liver cancer is crucial. This usually involves ultrasound or other imaging every 6 months, as early detection is key for better outcome. Then shall we go back into the Gilbert syndrome? Gilbert syndrome is an inherited metabolic disorder causing unconjugated hyperbilirubinemia. Jaundice occurs during intercurrent illness and prolonged fasting. Liver biopsy is often normal, and there is no specific treatment for that. Prognosis is excellent. This graph shows the comparison between the Gilbert and the Crigler-Najjar syndrome. As you can see, Gilbert syndrome is more common, and it reduces the bilirubin conjugation, whereas the Crigler-Najjar type 1, there is no bilirubin conjugation at all. Therefore, death can occur in infancy if untreated. But Gilbert and the Crigler-Najjar type 2 are similar, but the bilirubin levels are little different. However, recent research has opened up new possibilities for managing or even modifying this genetic disorder. Let's explore some of these. Gene therapy and gene editing. One of the most exciting areas of research is the potential to use gene editing to correct the gene mutation. Uh, Technology allows precise modification of DNA, and early stage studies in animal models have shown that it may be possible to directly repair the faulty gene responsible for the syndrome. This could potentially normalize bilirubin levels by restoring proper enzyme function. In addition to gene therapy, another promising strategy is using adeno-associated virus vectors to deliver the corrected gene into the liver cells. This approach has been effective in treating other liver enzyme deficiencies and could hold similar potential for Gilbert syndrome in the future. And the molecular chaperones. Another approach being explored involved the use of molecular chaperones, compound that help stabilize the enzyme. This drug could improve the enzyme's function in individuals with Gilbert syndrome, potentially reducing bilirubin levels. And pharmacotherapy. Historically, phenobarbital, a drug that stimulates enzyme activity, has been used to manage bilirubin levels. However, due to side effects, its use has been limited. Researchers are now investigating safer alternatives, new drugs that can increase the enzyme activity. And we know that certain lifestyle factors like fasting or dehydration can trigger episodes of jaundice in patients with Gilbert syndrome. Current research continues to explore how a balanced diet, proper hydration, and minimizing stress can help manage these fluctuations in bilirubin levels. There is also ongoing research into the role of antioxidants like vitamin E and N-acetylcysteine. These could help reduce oxidative stress in the liver, which may improve bilirubin processing and potentially alleviate symptoms. It concludes my presentation. Thank you for your attention, and I'm happy to take any questions. These are my references.
Dr. Jayamini,
Yes.
is it possible to just recap on how you differentiated between Gilbert syndrome and Crigler-Najjar clinically earlier? There's a slide.
Yes. This is the graph that you can see. This is the Gilbert is more common than Crigler-Najjar syndrome, and in the Gilbert there is reduced bilirubin. There is conjugation is happening, but the activity is less. But in the Crigler-Najjar type 1, there is no bilirubin conjugation at all. But in the type 2, there is bilirubin conjugation, but less than the Gilbert. And Gilbert plasma bilirubin is less than 3, whereas the Crigler-Najjar type 2 is less than 20. It is ranging 6 to 45. But when there is no fasting or when there is no hemolysis, the plasma bilirubin level in Gilbert is less than 3. Can you understand?
Thank you, Dr. Jayamini. Yes, thank you very much.
Right. Okay, I think there is no questions.
No.
I would also like to take a moment to
Jayamini, thank you very much for a very informative presentation. Anyway, so you skipped few slides, like I think the causes for hemolytic or the conjugated, so
yeah.
and the unconjugated bilirubin, better go through those two slides as well as to completeness. It's not directly related, but why don't you talk about FIB score? Because sometimes, we usually associate people with those issues that high SDLT levels and all these things. Why don't you let's just talk about just FIB score as well as, these two slides you just rushed.
Okay. These are the causes for unconjugated hyperbilirubinemia. It is mainly the hemolysis and the conjugation problems. Autonomic, autoimmune hemolytic anemias called reactive, drug-induced, mixed type, and warm reactive. And hemoglobin disorders like sickle cell anemia, thalassemia. And conjugation, hereditary disorders of conjugation, Crigg-Deniger syndrome and Gilbert syndrome. And red blood cell enzyme disorders like glucose 6-phosphate dehydrogenase deficiency. And red blood cell enzyme disorders like G6PD deficiency, pyruvate kinase deficiency, and red blood cell membrane disorders like ellipticis, mainly hemolytic conditions and conjugation problems. These are the causes for conjugated hyperbilirubinemia. It can be intrahepatic as
Yeah,
well as extrahepatic.
Here,
Yes.
Jayamini, now it's like this. Now you actually describe what are the causes for unconjugated. Could you please go to that slide again?
Yes.
Right. So now we have to, because very important to have the theory knowledge to look at the person in very sort of a, practical way. Now the patient comes with, suppose the person comes with some blood report or else some the yellowish discoloration, right? So the first thing you did is, okay, find the bilirubin level, and there, of course, you found the unconjugated bilirubin is high. Okay, now,
Yes.
now tell me, according to this list, what
Yes.
are the investigations you should perform in this patient to understand the possible causes?
Yes. We can do a smear, a blood smear first. And we
That's
can
me in
do
the sense like that picture. Yes.
yes, blood
Okay.
picture. And we
Then
can do the levels, D6PD levels.
before that, no, D6PD levels, of course, like as clinicians in the primary care, we can do a lot of things, right?
Yes. We can do the smear.
No, go to that
Different.
slide. I mean, from that we can just get a lot of things to that. So go to that particular slide.
Yes.
Okay. Now, accordingly, what is the most important thing now?
Blood
Is
smear.
it's the blood picture.
Blood picture. Yes.
So then what? What else now? What
And
else?
Coombs test.
Exactly, the Coombs test.
Coombs test.
So those are the two main things where you can order very easily, right? You don't have to go for anything. The blood picture and the Coombs test are the thing. Another thing, what are they? If it is thalassemia, any other thing?
Electrophoresis, madam.
Electrophoresis, or else yes, we can go HPLC electrophoresis.
Yeah.
What else? What else? Hemoglobin, which type you wanted to do?
HbA.
The hemoglobin type, any hemoglobin type you want to do? Why get this thing? The thalassemics. Anybody?
HbA.
Huh? Hemoglobin? Which hemoglobin? Anybody can answer.
HbA.
Hemoglobin.
Human levels.
Huh? What are the what? Because it's very easy things, no. We don't have to go for any like sort of all the levels like GCSPD levels. Okay, fine. It's once you refer the person to the some sort of a place where you think that the problem is it's little bit in a sort of advanced need any advanced investigations. Of course, there are secondary or tertiary levels where we can get the help. But for
Is it HbA2 levels?
HbA, what about fetal hemoglobin? Again, yes, fetal hemoglobin is there. So that we can ask HbA1c, all the things, the easy ways we can say could be thalassemia or the screen for thalassemia, all the tests which are available for primary care, right? And the other things is Coombs test, which is very easy. And the other one is blood picture, right? So then you can have some idea to exclude. So then only we can send this person for others. So what are the other drugs? That is the other thing. What are the drugs causing this? Any common drugs causing? Drugs induced one. What are the common drugs? That is the most important parts. You all to think. Drugs causing.
Anti-TB drugs, doctor?
Yeah, it could be anti-TB drugs specifically.
Acetopane and
But
isoniazid and
INH.
Oh, yes.
Right. So any other thing other than that, the common ones? If you see a patient with that one, how you get the drug history?
And herbal supplements?
No, herbals, of course, we cannot take it as all the sort of as a medication. But then even some, we do not know what are the things they take for as meals. Also, they can take different leaves and all those things. Herbs.
And also anti-malarials, primaquine.
Anti-malarials, of course. That's what. Yeah, this is the most important thing. The why we say, what are the instances we give anti-malarials? Not to the malaria. Huh? Any anti-malarial drug we use for, commonly used for not for malaria.
Rheumatoid arthritis.
Rheumatoid diseases. HCQS. So that's the thing. So you should know very common things first. Okay? Right. So these are the things you should know. Okay, fine. But it's very easy for you all to understand what are the common things. Right? Okay, fine. Shall we move to the conjugated one? Conjugated hyperbilirubinemia. Now, what are the things now? Like this, very simple. Or the liver profile. We'll say the hepatitis profile, right? And then the others, like for the things for the alcohol, like we know what are the things we should do. And what else? Again, there are drug interest one, definitely. What are the other things you should do here?
Mainly
the imaging part. Here we have to understand for the conjugated one, mainly it's sort of a imaging. There are different levels of imaging as well as the screening for the hepatitis and the alcohol. Right? So, and if there's a huge history of chronic sepsis, yes, again, it's a sort of a maybe CRP or whatever the things for the rule out that, but mainly imaging and the screening for the hepatitis. Right. So if you think that in this case, you need to do the FIBSCO as well. Now, just tell me about FIBSCO. Anybody? Anybody you can talk. Tarindra is also there. Why don't you talk about that? It's good for the others. There are like people like the juniors also there, so you can talk.
FIBSCO mainly done for people when we are suspecting of fatty liver disease to grade the severity.
So then here we are talking about this as well. No, now. Okay. Now then what? Now tell me. Non-alcoholic, like we said, non-alcoholic hepatitis also we say NASH or NAFLD, all these things we are talking about. Now tell me, starting from.
The indices we use are the platelet, the LTST levels, And according to that, there are 3 grades where it's from less than 1.6, 1.6 to 2.6, and more than 2.6.
Yeah.
So if it's more than 2.6, then it's an indication for a fibroscan and further management. All the other 2 levels are managed by dietary and lifestyle modifications.
Yes. So that is the most important thing, because here also we do the imaging. Before that, even we can go for that as well. And then because as primary care physicians, we can do a lot, not to do a lot of investigation, but for the very fine things, like very easy things. We can do a lot by like giving some sort of even the lifestyle modification. If the FITCO is, up to this, this level where we can treat. So it's important to have that knowledge. I think Jayamini better include that one slide.
Okay, madam.
Okay.
Okay, madam.
And the other things we discussed for the early 2 slides, what are the investigations to rule out? I think better do those things, right?
Okay.
Okay, right, good. So anything? So, but because you are the very advanced ones are very good, that is how you have to do, because it should be look forward. These are the things the world do, and we have to understand is there are things available for people, though we are not doing currently here, but still it's available for people. If they ask those questions, we must have answers for those things. Any questions? It should be a good sort of a platform for you all to talk. Right. If the person's unconjugated levels are very high, what are the other symptoms which gives you like red flags? Okay, fine. We have to do a very act promptly. What are the red flags? We say like that. What are the red flag signs with high unconjugated bilirubin level? Either symptoms or signs.
Anemia, severe anemia.
Yeah, severe anemia, like very low HB level. Okay, fine, it's an investigation. But anyway, the person presentation, like what are the
Severe jaundice, madam.
Yeah, severe jaundice with what with the severe jaundice and anemia? What are the things? What are the possibilities in the person's presentation?
Dark urine.
Yeah, so this just the dark urine. Okay, fine.
Neurological symptoms like kernicterus.
Splenomegaly.
Splenomegaly.
The organomegaly is a one, of course, splenomegaly. And then what else?
Hemoglobinuria.
Okay. But any symptom or symptom?
Confusion.
SOB, shortness of breath.
of breath.
SOB, it's very important. SOB, short of breath. What else? One is short of breath. The other one?
Chest pain.
Okay, but anything like chest pain is very subjective thing, no? How about appetite? What are the causes? What are the again? You go to that slide. It's easy for you all to understand. Don't try to. Come on, the page. Go to that slide. So look at this. What are the things here? By looking at this, what are the things you should do? What are the dangerous things? The myeloproliferative neoplasms, take it as, right? So how they present?
Bone pain, joint pain, fatigue.
Hmm. So you are not ready to answer the questions.
Other hyperviscosity symptoms, headache, vertigo.
Headache, yes, headache, headache,
Fever and recurrent
pruritus,
infections. But
headache, pruritus, blurring of vision. What else? SOB. So those are the things we should consider if a patient's unconjugated bilirubin level is high, and those are the things you have to look for. Just unconjugated level high and just go through the next level of investigation will not help. So you have to, first of all, you have to try to understand, are there any risk factors or the red flags in this patient? At the same time, you have to prepare the basic investigations which we sort of discussed so far, and then try to find the way out for this problem. If those are like sort of abnormal, then you can investigate on that line. If not, then you have to refer the person with available data. Okay, you must have some sort of a differentials for the next level. So it's easy for the next level person, either a secondary or tertiary care person, to start investigation from that level, not from the A. So it's your duty to do the best for the patient when you see. So before you refer the person to the next level. So it is mandatory right now, because at the exam for MDs, I'm telling you, you cannot just say these are the things is not available, refer the person. It's not like that. It's, you have a very huge duty on this regarding the, even for the referrals, because you are responsible for the patient, though the patient belong to that particular secondary or tertiary care person, you are responsible for the patient. Because of that, you should know what are the things you should do before you refer. But anyway, the conjugated ones, of course, very straightforward, because we know the problems specifically in the liver. So where liver or related structures there, the pancreas or whatever. So the imaging, and there are a few sort of investigations are there. Right. So are there any other questions? Likewise, you should think like that, not the way that not like syndromes. This is good that Gilbert is, we are like very worried when you see a young adolescent with this icterus. So you get sort of okay, panic, can do all the sort of referrals, or even the people get the patients also get panic. They thought they will definitely think of a very bad, like very serious condition. For that, this knowledge is very important for you all. But not only that, so you must know that with these type of presentations, what is the duty of the person who is see the person at the very beginning. So the primary care, the primary care is the entry point for the healthcare system, either as medical officers or the diploma holders, or as the sort of PG trainees in the like registrars or the senior registrars. So you must have some questions. So even it's good for you all to think how we do as a long case or the OSCE, like this type of a presentation. You must have, I'm telling you what are the questions you should ask, what are the investigations you plan. You must have pre-prepared things. Even for this type of presentation, you must have a pre-prepared. It's not only just the icterus or the yellowish discoloration. You have to do it like that, according to the gender wise, like the age wise. The young male with very young, in the sense teenage, like this person, or the old age person, right? The female is different kind. So there you should know each and every steps or each and every presentation, what are the questions you should ask to rule out the according to your priority list, because it changes with the age and the gender. So I think it's a good exercise for the registrars to go through, and we have to prepare for those things, and you don't have to worry even at the exam, So these are the questions I should ask. So I'm now talking where the others, of course, do not talk. It's not nice. Okay, then.
I would also like to take a moment to sincerely thank Madam Lalanta for her invaluable guidance and support throughout this process. I truly appreciate her mentorship and I'm grateful for the opportunity to present today. Thank you, Madam.
Uh, Thank you, Dr. Jayamini, for that very enlightening presentation. And thank you, dear madam, for your kind guidance provided as always. In the absence of questions, I think we can conclude for today. So we will be meeting again in another week with another session. Till then, good night.